Just get a minute or two for people to just join. Usually they join in about a couple of minutes. Maybe give it another minute and see, make sure that. All right, I think we're going to get started. Welcome to the Grand Rounds. Today, we have a distinct privilege to have a very esteemed colleague, Dr. Philippe Pibarot, who's going to give us an insight on some of the very mystical aspects of aortic valve disease, specifically aortic stenosis. And before we go into the Grand Rounds, I will go ahead and try to share my screen for the specific aspects of the presentations and the CME requirements. So this is our Grand Rounds website, and the cardiology website is posting all the Grand Rounds. So you are able to go and see them and refer them to your colleagues in the future after it is recorded as well. We are offering CME credit for this session. For that, you please text 12463 to the number 888-816-4893. And you can do that for the next 12 hours after the session. You should be in form of an SMS message, and you should have an active profile in the Cloud CME platform. For physicians, also, we provide the MOC. And for that, please complete the CME steps. And we will bring this again in the chat box so that you can also do it while during the presentation is being done. For that, you have to complete the step 1 and then have a link to the multiple choice questions that are presented at a link. The room code is future15. And once you do that, you will have your maintenance of certification point directly link into your online ABIM ID as well. With that, it's my pleasure and honor to present to you Dr. Philippe Pibarot. Dr. Philippe Pibarot obtained a doctorate in veterinary medicine at University of Claude Bernard in Lyon, France, and also PhD in biomedical sciences from the University of Montreal. And he has appointment in the Department of Medicine of Laval University and holds the Canada Research Chair in valvular heart disease at Quebec Heart and Lung Institute. He also heads the cardiology research program at the Quebec Heart and Lung Institute. He's one of the most preeminent voices and thought leaders in valvular heart disease in the world currently, and is almost single-handedly impacted several clinical trials and is involved in either doing core lab activities or guiding the work in several leading clinical trials in the industry. He has been forthcoming and is with his interest on patient-oriented approaches for valvular heart disease. And when I was looking through his CV, it was astounding to encounter over 750 peer-reviewed publications and book chapters, enormous thought-provoking contributions to several conferences, several appointment as a reviewer and editorial board member in elite and high-impact journals. And also he has had several contributions in funded grants and clinical trials. He's associate editor for structural heart and neurointervention journals and imaging section editor for the Journal of American College of Cardiology. He has received several awards, and the one which I have had the esteemed honor of sharing with him has been the Feigenbaum Lecture Award at the American Society of Echocardiography. He's a voice and a force to reckon with. And I've been so pleased and so honored to have been able to collaborate recently with him on several of the work together. And today we are going to be really excited to hear his thoughts on aortic stenosis. This is a very important and yet a very controversial field. And I'm sure he's going to provide his insights on how best we can serve this group of patients in the community and thereafter. Philippe, the floor is yours.
Thank you so much, Parto, for this kind introduction. It's a great pleasure to present at your grand rounds, and I felt that for this grand round I would present, a topic that is I think timely, exciting, and also controversial in the diagnosis and treatment of aortic stenosis. So I selected the hottest topic, if you will, in aortic stenosis for this grand round. Before getting started, I do have some disclosure that are listed here. As Parto mentioned, we are the co-lab for several of the TAVR trials currently ongoing. So in aortic valve disease, the timing of intervention is key. Timing is everything, right? So and the guidelines came up with this notion of staging the disease progression. So you have the patient at risk for AS. This includes patients with bicuspid aortic valve, aortic sclerosis, stage A. And then the stenosis per se develops, and you have mild, moderate AS. That's what we call stage B. And for this stage A and B, the recommendation is to follow the patient, okay? No indication for intervention at this stage. Then you come to severe AS. And when you have hemodynamically severe AS and the patient has no symptoms, no LV dysfunction, this is what we call stage C1. As we'll see, there is some indication for intervention, but the dilemma in this patient is, should we intervene now, so early AVR, versus more a surveillance or watchful waiting strategy? And this is a hot topic at the present time. And then you got the patients for whom we already have clear class 1 indication for intervention in the guidelines. So these are the patients with severe AS who are asymptomatic but have LV dysfunction, LV systolic dysfunction, so an EF less than 50%, the stage C2, and as well the standard, let's say, severe AS symptomatic patients, stage D, who, of course, we need to intervene to do aortic valve replacement now. So the next frontier, or the first frontier I would like to discuss with you, is this group of patients with asymptomatic severe AS, so the stage C1, because a lot of is happening on this subset of patients. So let's start with a case. 65-year-old woman, history of calcific AS, as you see the valve is calcified and thickened. She's asymptomatic and true asymptomatic. This is confirmed by exercise testing. BNP ratio is 2, so kind of elevated for the age and sex of the patient. LVEF by biplane Simpson 60%, so preserved. And if we look at the valve, well, it is not looking good. Severely thickened, calcified, restricted opening. And hemodynamically, we have a peak jet velocity of 5.1 meters per second. 1 year ago was 4.8, so a progression of about 0.3 meters per second in the past year. The mean gradient is 64, quite high. Valve area by continuity equation is 0.65, index 0.35. So by all means, this is a severe, even very severe AS in a patient who is asymptomatic. Okay, so the dilemma that we have with this patient, should we do the AVR now? Because anyway, the AS is severe, and sooner or later the patient will need AVR. That's one possibility. The other possibility is what is still recommended in the guidelines, is watchful waiting. So wait for the onset of symptoms and or LV dysfunction to intervene. And if we look in the guidelines, this is the algorithm that you have in the most recent edition of the American guidelines, the ACC AHA guidelines. In patients who have no symptoms, such as the patient we discussed, and severe AS, so peak jet velocity more than 4, obviously here, well, you see that there is a class 1 indication in green for SAVR or TAVI only if you have an LVEF less than 50%, that's the stage C2, which is not the case in the patient, or if you have an indication for another cardiac surgery, for example, a CABG, which is not the case in this patient. Otherwise, there is no other class 1 indication. But you do have some risk marker that you may consider to eventually envision an earlier intervention, and that would be a SAVR in this case. For example, if you have a reduced blood pressure or exercise capacity on an exercise testing, then the patient is not really a true asymptomatic, then of course, you need to consider intervention. Otherwise, if you have a very severe AS defined as a peak jet velocity more than 5, or BNP ratio markedly elevated, more than 3-fold in terms of ratio, or a rapid disease progression, which is defined in the guidelines as a progression rate of the peak velocity of 0.3 meters per second or more. And also you need to have a low surgical risk. And if you have any of these 3 risk marker, low surgical risk, well, there is a class 2 indication for valve replacement. So in the case that we just saw, she has a very severe AS. She has a rapid disease progression. She's just on the edge, 0.3 meters per second. She is low surgical risk, but she has a BNP ratio that is elevated, but not markedly elevated. So we could eventually consider an earlier intervention as per the guidelines. But also a watchful waiting, careful clinical surveillance would also be reasonable. So one of the things that is important in this patient is not only look at the hemodynamic severity, the valve area, the gradient velocity, but also look at the valve per se, And we learned that, from this seminal paper, by Rozenek and colleagues in New England Journal of Medicine. If you have moderate or severe calcification, semi-quantitatively assessed by echo, the risk of worse outcome is increased in the asymptomatic patient with severe AS. And of course, after looking at the valve anatomy and function, we need to look at the left ventricle, because at the end of the day, it's not the valve disease per se, the stenosis per se, that will eventually kill the patient. It is the repercussion, the consequences of the stenosis on the cardiac chamber, the left ventricle and other chamber, that will eventually determine the outcome. So it's important to look at the left ventricle. But when you look at the left ventricle, we need to look beyond the LV ejection fraction, because the LV ejection fraction, if you only look at the LVEF, you may conclude, oh my God, good LV function. It's a beautiful day with a beautiful sea and beautiful blue sky. But if you look at parameters that are more sensitive than the LV ejection fraction, the history and the conclusion might be different. So, and this is very well, I think, highlighted by these recent studies that have been done. This is a study from the Mayo Clinic, where you clearly see that if you have LVEF below 50%, as you have in the guidelines to trigger intervention, clearly the survival is markedly reduced, and in the short term. So that's a no-brainer for this patient with a low LVEF, lower than 50%, intervention as soon as possible. If you have LVEF more than 60%, this is the blue curve, good survival. So I think in those patients, you can certainly do watchful waiting, it's fine. But look at the patients who are in the intermediary stratum, so between 60 and 50%. Well, actually, these patients, they have a worse outcome compared to those with LVEF more than 60%. And you see an impact even in the short term. So these patients, obviously, they have subclinical dysfunction that is not identified by the LV ejection fraction per se, and they are at high risk for worse outcomes. So I think an LVEF, I've always felt that an LVEF of 50, 55%, 57% is for a patient with AS and LV concentric hypertrophy is already too low. and that certainly in the guideline, we should consider maybe more an LVEF cutoff for intervention of 60% rather than 50%. And indeed, in the recent edition of the guidelines, you have this new recommendation. If the LVEF decreases below 60% on at least 3 serial imaging studies, echo or other imaging, well, you could consider an earlier intervention, but it's a class 2B, I think, So and eventually the strengths of the indication might be reinforced in the future with accumulation of new evidence. The other way or alternative that we can use to improve the sensitivity of LV ejection fraction to detect subclinical dysfunction is to use another parameter, which is the global longitudinal strain that we can easily measure by spectral tracking imaging. And in this meta-analysis, you see that if you have a global longitudinal strain less than 14.7%, let's round it to 15%, minus 15%, well, you have reduced survival. And these were patients with asymptomatic AS and preserved LV ejection fraction. And you see that in these patients were no symptoms, LVEF more than 50%, well, the global longitudinal strain that is reduced, and that was approximately 1/3 of the cohort, identified patients who are at risk of worse outcomes. What is also interesting is that even in the subset of patients with an LVEF more than 60%, where you would say, well, these patients, a priori, they have no issues with LV systolic function. Well, again, here, even in these patients with LVEF more than 60%, you have 1/3 of the patient who have reduced longitudinal function, a GLS that less than 15%. And these patients have a reduced survival. Now, we look at the left ventricle, that is fine, but we need to look at all cardiac chambers. We need to go upstream and look at the left atrium, the pulmonary circulation, the right ventricle, etc. And this is where I would like to introduce this concept of cardiac damage staging, of staging the cardiac damage versus grading the severity of aortic stenosis. And I think there is an analogy to make with oncology. Our colleagues in oncology, when they assess a patient with a cancer, they will grade the severity of the tumor, of the primary tumor per se, and then they will stage the extension of the tumor. And with this two-fold assessment, they are able to guide and optimize the therapeutic management. Well, I think we should do the same in cardiology. Of course, we need to continue to accurately grade the severity, anatomic and hemodynamic severity of the causal lesion, which is aortic stenosis. But we also need to assess the repercussion of this stenosis on the cardiac damage of the 4 chambers. And this is where we can use this staging of cardiac damage that we proposed initially with Philippe Généreux in the context of the Partner 2 trial, and that we then adapted and applied to this population of asymptomatic severe AS. So this is a very simple classification that we propose that is based on several echo parameters and criteria that are used in routine practice and that you have in the guidelines. So stage 0 means there would be no cardiac damage at all, which is of course rare in patients with severe AS. Stage 1, damage at the level of the left ventricle. And if you have increased LV mass index using the usual cutoff for male and female, or grade 2 diastolic dysfunction or more, or an AF less than 60%, why not 50%, but more 60%? Because again, this threshold is more sensitive, as we just saw, or a GLS less than 15% or minus 15. And if you have any of these criteria, you qualify for stage 1. You don't need all, okay? Stage 2 means damage at the left atrial mitral valve damage with enlarged left atrium, moderate severe MR, and or AFib. AFib is the only non-echo parameter in this classification. Stage 3, pulmonary arterial tricuspid valve damage with systolic pulmonary hypertension. This defined as a systolic pulmonary arterial pressure of 60 or more, and or moderate severe TR. And finally, stage 4 means damage at the level of the right ventricle, defined as moderate or severe RV dysfunction. And we know that when we have a patient with whatever cardiovascular condition or valvular disease, when we start to see some RV dysfunction, this is not a good news. We also put in stage 4 presence of moderate or severe low flow state, defined as a stroke volume index lower than 30, because the stroke volume is an overall marker of the pump function of the heart, and it could be caused by damage at different level of these cardiac chambers. So we put that at the stage 4 because we felt it's maybe the first step or the first phase in the heart failure, in the cardiac decompensation, although the patient is still asymptomatic, right? So we applied this classification in a multi-center study that included the population of several heart valve clinics in several countries. And the results were quite interesting. First, you see the distribution of the staging. This is an asymptomatic AS population. Well, stage 0, only 12%, okay. Stage 1, 27%. The most prevalent stage was stage 2. I would have expected more stage 1, and no, it was stage 2, although this is still an asymptomatic population. And finally, stage 3 and 4 that we merged together, 14% still. And what is interesting is that 61% of these patients were asymptomatic, and the asymptomatic status was confirmed in the context of heart valve clinic by exercise testing, etc. So it's true asymptomatic. Eh? Well, they had evidence of advanced cardiac damage staging, so stage 2 or more. So my point here is that the absence of symptoms in the patients with severe AS or moderate AS is maybe falsely reassuring. If you have symptoms, okay, then it's a no-brainer. It's a stage 2, it's a stage D, and it's a class 1 indication for intervention. But if there is no symptoms, it does not necessarily imply that there is no cardiac damage. And maybe in this population, we should move away from symptoms and look more at our echo. So, and it predicted prognosis very well. If you have, well, stage 0 is the blue curve, it's fine. And stage 1, you start to see some increase in mortality, but this is an increase in mortality beyond 3 years. So in the short term, I think stage 1, it's okay to do watchful waiting, a clinical surveillance, and not intervene. But then as soon as you are in stage 2, you see that the risk of mortality increase, and in the short term, in the first year, and of course, stage 3 and 4 also. So there's already been some trials that test the timing of intervention in this asymptomatic severe AS population. This is a small trial from South Korea, published in New England in 2019, where you see that this is about 70 patients in each arm, so small sample size, but still good proof of concept, where you see patients who were, these were patients who were asymptomatic, very severe AS. So it's not all comer with severe AS. One of the inclusion criteria was a peak jet velocity more than 5, okay? And you see that with conservative management, there is increase in mortality, all-cause mortality or cardiac mortality, and that is significantly higher versus early surgical aortic valve replacement. So there are other ongoing trials that are include larger sample size, in particular the early TAVI trial that is ongoing, where we recruit patients with asymptomatic severe AS. So that's all comer with severe AS, not only the very severe AS. Patient needs to be older than 65, absence of symptoms confirmed by treadmill stress test, and they are randomized to a transfemoral TAVR versus a clinical surveillance. And the primary endpoint is a 2-year composite of all-cause deaths, all stroke, and repeat rehospitalization. The recruitment in this trial is now completed, and we are now doing the follow-up. So that's my first series of conclusion for this first frontier, let's say. So in asymptomatic severe AS, so the stage C1, there is no class 1 indication for aortic valve replacement in patients with asymptomatic CVAS, unless, LVEF is less than 50%, of course. A class 2A indication for AVR, if the patient has this risk marker, so very severe AS, defined again as a peak jet velocity more than 5, fast stenosis progression rate of 0.3 meters per second per year, or elevated, markedly elevated BNP, so BNP ratio of more than 3. There is a class 2B indication for AVR, and that's a new one in the recent edition of the guidelines, if the LVEF decreased below 60% on 3 serial imaging studies. And as I mentioned, I think this new concept of cardiac damage staging may be very helpful in improving risk stratification and maybe better individualizing the timing for intervention in this population. Because I don't think that, regardless of the results of the early TAVI trial and others, this would be average results. And if it's positive, it does not necessarily mean that an earlier intervention is good for all patients, and vice versa. Of course, a watchful waiting may not be good for all patients. So we need to better individualize the strategy and improve risk stratification. And as we just discussed, there are several ongoing trials, and the largest one is early TAVI. The second frontier is this issue of paradoxical low flow, low gradient AS. So we fall into a separate subset of the stage D, so where a priori we have severe AS, but that's patients with low flow, low gradient. Always challenging patients. I'm going to try if the videos are playing. Yeah. In low gradient AS, this is maybe one of the most challenging condition in valvular disease. So this is defined as a valve area that is less than 1 centimeter square, consistent with severe AS, but with a low peak velocity and low gradient, so mean gradient less than 40, consistent with non-severe. So we have what we call a discordant gradient at resting echo. And this is always difficult, and this is frequent situation. I'm sure you're seeing that often in your practice, unfortunately. And there are 3 subgroups of low gradient AS. You have those with reduced LV ejection fraction. That's what we call the classical low flow, low gradient. That's in fact the HREF form of AS, if you will, D2 stage in the guidelines. And then you have those with preserved DF, and they have preserved DF, but the stroke volume index is lower than 35 ml per meter square. So they have a low flow state despite the preserved DF. And that's why we call them the paradoxical low flow, low gradient. That's the HPEF form of AS, and in the guidelines, they are labeled at D3 stage. And then there is another category that we won't have time to discuss today, but they are not really well addressed in the guidelines, and that's what we call a normal flow, low gradient. So these are patients who have preserved DF, normal flow, at least according to stroke volume index, but they still have this embarrassing discordant grading where you have a small valve area, but with a low gradient. So this is an example of a patient with paradoxical low flow, low gradient AS, 82-year-old woman. This entity is indeed more frequently seen in elderly people with often concomitant hypertension, such as in this patient. She has no evidence of CAD. She is functional class 3 at recent heart failure hospitalization. LVEF, as you see, well, by biplane Simpson, we got a 65%. Visually also, it's clearly not reduced. The global longitudinal strain, however, by spectral tracking is reduced at 13%. She has a grade 2 diastolic dysfunction with evidence of increased filling pressure. AS severity on echo, well, 0.64 by continuity equation, index 0.36, Doppler velocity index that I always like to look at is 0.19. So all these parameters are severe, clearly severe, but the mean gradient is only 26, okay? And peak gradient 44. So we have a discordance between the valve area versus the gradient. And well, this discordance may well be related to low flow state, because look, the stroke volume index is 29 ml per meter square. And indeed, okay, this patient has a preserved DF, but look at the very pronounced concentric remodeling, small cavities, impaired filling, impaired longitudinal strain. So you have, I think, good reason to explain the low flow state. Of course, in this patient, you need to be very careful to well measure the LVOT diameter, because if you underestimate the LVOT diameter, you will underestimate the stroke volume, valve area, etc. Also, very important to do a careful multi-window interrogation with continuous wave Doppler that includes the apical views, but also the right sternal border and the suprasternal notch, in order to be sure that you get the maximum gradient and that the gradient is not underestimated. And just before moving to the next slide, look at the valve, okay? In this case, you saw the video clip. It was severely thickened, calcified with restricted opening. So what do we have in the guidelines for this patient with paradoxical low flow, low gradient, the D3 stage? This is the definition that you have in the guidelines. So severe valve area, severe index valve area, low gradient, preserved DF, low flow, defined as a stroke volume index lower than 35. And it is recommended now in the new edition of the guidelines, both the American and the European, to use calcium scoring by CT, non-contrast CT, to adjudicate, to confirm the stenosis severity in this patient, because you have a discordant grading at the resting echo. You cannot conclude if the stenosis is severe or moderate. You need something else to do the tie break, right? Dobutamine stress echo is not the ideal test for this patient, as we would use in classical low flow with low EF. But in paradoxical low flow, what is recommended is to use CT. And the recommendation for intervention are the following. AVR is recommended in these patients if they are symptomatic and if the stenosis severity, the presence of severe stenosis is confirmed eventually by cardiac CT. And it's a class 1 indication now in the recent edition of the American guidelines, and it's still a 2A in the European guidelines. Why do we have a discordance between the two guidelines with the same evidence? Sometimes difficult to understand, but this is what it is. So this is an algorithm that I like, that is from the European guidelines, where if you have a discordant grading with a small valve area and low gradient, first thing, exclude measurement error. Double check the measurement of the LVOT diameter, the assessment of gradients, etc. Then define the flow LVEF status. If there is a low EF with low flow, this is the classical low flow, low gradient. What is recommended is a low dose dobutamine stress echo, as shown on the left, to differentiate a pseudo versus true severe ES. Okay. On the other end, if you have this preserved EF but with low flow, so the paradoxical low flow, then dobutamine stress echo is not the ideal test, and the guidelines recommend an integrated multi-parameter approach, but that is essentially based on the calcium scoring by a non-contrast CT. It's a very easy and fast exam to perform, low radiation exposure, so I think we should not hesitate in this patient to corroborate the stenosis severity by calcium scoring. In the patient I showed you, very high calcium score, especially for a woman, because the cutoff for considering severe ES, true severe ES, are different in men and women. So it more than 2,000 in men and 1,200 in women. And here, this is a woman with a calcium score of 3,200. This is very high. So clearly, this patient has a true severe ES. She underwent TAVR and went well. Now, a little parenthesis to mention cardiac amyloidosis. Why? Because in this population, particularly the patient with paradoxical low flow, low gradient that we just saw, the prevalence of cardiac amyloidosis may be found in up to 15% of the patient. And sometimes it is difficult, to differentiate an hypertrophy and echocardiographic features that are related to the aortic stenosis versus the amyloid. So you need to look for the red flags of cardiac amyloidosis, especially if you have a biventricular hypertrophy, if the right ventricle is also hypertrophied, if you have an hypertrophy of the interatrial septum, and you have this sparkling appearance of the myocardium and generally enlarged left atria, impaired longitudinal strain with apical sparing. That's all signs, all red flags that you may use. Also look at clinical red flags, history of carpal tunnel syndrome, spinal stenosis, etc. ECG also red flags, like especially if you have a low voltage despite LVH, pseudo infarction pattern, And right bundle branch block also is an important one. And if you have these red flags, don't hesitate to go with a confirmed diagnosis by bone scintigraphy and analysis of light chain in the blood and urine. And having said that, now let's say that you confirm that patient with paradoxical low flow, low gradient as a concomitant cardiac amyloidosis. Well, still, well, eventually you will treat the cardiac amyloidosis with pharmacotherapy, tafamidis or other, but you also want to still confirm the stenosis severity. And as I said, the best modality to do that in patients with paradoxical low flow, low gradient is to use a non-contrast CT to assess the calcium score. There is a little pitfall here that is you may have false negative with calcium scoring in patients with concomitant amyloidosis. Why? Because there is more and more evidence that cardiac amyloidosis may also be involved in the initiation and progression of the aortic stenosis per se. In other words, there is probably an amyloid form of aortic stenosis. And so you have deposit of amyloid substance, not only in the myocardium, but also in the valve and in the aortic valve that leads to thickening and stiffening of the valve and aortic stenosis. And of course, the amyloid substance, as well as the fibrotic tissue, is not detected, is not visualized by a non-contrast CT. So you may have some false negatives. So you need to be comprehensive. There are new, let's say, imaging perspective that will probably allow us to overcome this limitation, which is to use a contrast CT instead of a non-contrast. And using some standardization method and normalization with the blood pool, we are able now to measure the volume, not only of calcium as shown in green on these images, but also the non-calcified tissue, the volume of non-calcified tissues of fibrosis, amyloid, etc., which is shown in red in this image. So when we come to the point where we have confirmed the presence of a severe, true severe AS in a patient with paradoxical low flow, low gradient, well, of course, we need to now select that. We know that there is an indication for intervention for AVR, but it is now important to select which is the best type of therapy. Well, typically in patients with low flow, low gradient AS, classical or paradoxical, the least invasive approach is the best. So if you can, you should prefer transfemoral TAVR versus SAVR or versus alternative access TAVR. And anyway, AVR, whatever is the type, is better than conservative management. These are the results of the TOPAZ study that we have initiated like more now than 25 years ago. It's an observational non-randomized study. So, but we did the careful inverse probability weighting to compare the different type of therapy. And clearly the least invasive approach is associated. So transfemoral TAVR is associated with the best outcome in this patient. So to summarize, for this low gradient AS, dobutamine stress echo is useful to confirm stenosis severity in the classical low flow, low gradient AS patient. So those with the low EF. So clearly dobutamine stress echo for this patient is the primary modality to consider to adjudicate the stenosis severity. On the other hand, in the other types of low gradient AS, especially the paradoxical low flow, low gradient, the best modality to adjudicate the stenosis severity is a non-contrast CT. And it is now recommended to use this modality in the guidelines. AVR is recommended, and this is now a class 1 in patients with classical low flow, low gradient severe AS, once you have confirmed the presence of severe AS, and same class 1 indication for AVR in those with paradoxical preserved EF low flow, low gradient patient, just as the one I showed you, after, of course, confirmation of the severity of AS by calcium scoring CT. And finally, transfemoral TAVR is preferred versus SAVR in, I would say, all types of low flow, low gradient AS, because these patients are more vulnerable. So you need to address them with a less invasive approach. Just be careful, you know, in patients with low flow, low gradient, especially those with paradoxical low flow, low gradient with preserved EF, especially when they have this pronounced concentric hypertrophy. Look for red flags of cardiac amyloidosis, and if any, confirm the diagnosis. And CT angio may improve actually the quantification of the Fibro-Calcific burden on the aortic valve in the low flow, low gradient AS, especially those with concomitant amyloidosis. The third frontier I would like to discuss with you is even maybe more provocative, is the what to do with the symptomatic at-risk moderate AS. That is still, considering the guidelines stage B. So a priori, no indication for intervention. And indeed, if you look at stage B on the right here, well, there is no indication for AVR, SAVR, or TAVR, unless there is an indication for another cardiac surgery. So, for example, the patient will undergo a CABG. Then you may consider replacing the valve at the time of the CABG, even if the stenosis is moderate. But even there, it's a 2B recommendation. It's not that very strong. Let's look at this case. This is a patient with low EF and discordant grading. Again, at resting echo, you see LVEF is 20%, so quite low. Severe low flow state with a stroke volume unindexed of 36. Mean gradient 22. And valve area 0.85. So we clearly have a valve area that's severe, but with a moderate gradient. So typically in this patient, we have a low EF, low flow. We do a dobutamine stress echo, as we just discussed. Fortunately, the patient has a good response to dobutamine, improves LVEF to 30%, stroke volume to 55. And so there is some flow reserve, some contractile reserve in this patient. And now you see the gradient increase to 32, but at the end of the dobutamine stress echo is still moderate, not severe. And the valve area that was severe is now becoming moderate at 1.2. So dobutamine stress echo has reconciled the gradient and the valve area that are all now in the moderate range. So what we conclude is that this is what we call pseudo-severe AS, right? This is not true severe AS. There is no indication for AVR in this patient, at least until now. And this is pseudo-severe AS, but pseudo-severe AS doesn't mean no yes. This is still a good moderate AS. And the next question is to say, well, okay, moderate AS, but is this moderate AS really benign for this very bad ventricle? Well, the answer is no. This is the first the results of this very large study from the National Echo Database from Australia, the MEDA registry, where actually, and so that's all comers with moderate AS, mild AS, severe AS, regardless of the LV ejection fraction. And what you see in the bar in black is the mortality at 1 year and blue at 5 years. Okay, and well, the reference group is the patient with no aortic stenosis, and you see that with mild AS, you see some increase in mortality at 1 year and 5 years. But with moderate AS, the step is even more pronounced, and you see that the patient with moderate AS actually almost have the same risk of mortality as those with severe AS. So the prognosis of moderate AS is not benign. This is a study that we did some years ago, 3-center retrospective study of patients with moderate AS, but here it's all patients with LVEF lower than 50%, and their outcome is not good. By 4 years, 61% had either died, underwent AVR, or had been hospitalized for heart failure. So the point is, I think the take-home message is what is moderate AS for a good ventricle may actually be severe for a depressed ventricle. And further evidence, more recent paper that we did again multi-center. Here, what we did is that maybe that was missing in the first paper that we did. We had a group with HREF, but no AS, like a control group that we matched with a propensity score to the group with HREF and moderate AS. And interestingly, you see that if you have the HREF group is the that's the cumulative incidence of mortality is the black curve, and you see that the patient with so that's HREF only, no AS. Red is the HREF with moderate AS who underwent valve replacement, and in such case, you see that there is the outcome is almost is similar to the patient with HREF and no AS. But on the other hand, if you look at the patient with HREF, moderate AS without intervention, the blue curve, you see that the prognosis is much worse than the other groups. So again, I think it's all a question between the magnitude of the pressure overload imposed by the stenosis versus what the ventricle is able to handle. So again, the moderate AS will be well tolerated by a patient with a good LV function, but the same moderate AS may actually poorly tolerated by a patient which is in systolic heart failure. So this led us to design this trial, which is, I think, a provocative trial. That's the provocative trial. That's the TAVI trial. 300 patients with moderate AS, eventually confirmed by dobutamine stress echo, reduced systolic function, so LVEF less than 50%, optimized heart failure therapy, and they are randomized to TAVR now, although the S is moderate, because we believe that the moderate S is detrimental for this patient in systolic heart failure. So randomized to TAVR versus medical therapy. And so this trial is still ongoing, but it's going to be interesting to see what will be the results. There is another one that just started. That's the PROGRESS trial. So the PROGRESS trial, same concept, patient with moderate AS, but here it's more, it's a broader inclusion because it needs to be moderate AS with symptoms or evidence of cardiac damage dysfunction, as we previously discussed. So we are focusing on patients who have at-risk moderate AS. It's not all moderate AS, but it's larger than the TAVR unload trial that focused mostly on the patient with a low EF. Here you can have patients with, for example, preserved EF, but low flow state, such as the paradoxical low flow, they would be included. So it's 750 patients, randomized 1-to-1 to, again, TAVR versus clinical surveillance. And the primary endpoint is all-cause mortality, stroke, or cardiovascular rehospitalization. So this is just to summarize, this concept of grading the severity of AS. Again, we have the stage A, that is aortic sclerosis, BAV. Stage B, or grade 1 would be mild AS, grade 2, moderate AS, grade 3, asymptomatic severe AS, and grade 4, symptomatic severe AS. And then you have in the columns the staging of the cardiac damage, stage 1, 2, 3, 4. And well, of course, if you have symptomatic severe AS, regardless of the staging, there are already indications for AVR. Okay. Now, if you have asymptomatic severe AS, well, there are several ongoing trials, including early TAVR, EVOLVE actually has been published recently, EASY AS that is ongoing. And these trials, there are more all-comer trials, but some focus on patients with more advanced cardiac damage staging. And now you have the grade 2 or, the moderate AS, where here there are several trials that are ongoing, TAVI unload, PROGRESS. Also, there is another one that is called EXPAND that will start soon. And they're all looking not necessarily at all comers with moderate AS, but at-risk moderate AS, okay? Now, so what I would like to conclude with regard to this symptomatic at-risk moderate AS is that, again, moderate AS is not a problem for a good ventricle. But in a failing ventricle or in a patient who has some risk marker, it may be detrimental and it may have an impact on outcome. So, and clearly there's more and more evidence that moderate AS overall is not benign. And particularly if it is associated with heart failure or cardiac damage, well, it is associated with poor prognosis. At the present time, just to be clear, there is no indication for AVR in patients with moderate AS, okay? If you look at the guidelines, nothing, unless, of course, the patient is undergoing concomitant cardiac surgery. But I think at least if you have patients with moderate AS who have some risk marker, maybe a closer clinical echo follow-up, maybe more every year, it is recommended for these patients. And the benefit of early TAVI versus clinical surveillance in the at-risk moderate AS is currently being tested in several trials. So the last frontier I would like to discuss in the next 5 minutes is something that I think would be very exciting, especially for Dr. Sengupta, which is the AI-guided risk stratification and management of aortic stenosis. I think artificial intelligence could have an important contribution. It's maybe more a bit futuristic, but the future is close, I can tell you. This is a paper and a collaboration that we had with Pibarot and his group. And this was really a very efficient collaboration. Mark Dweck, also from Edinburgh, was involved. And using actually machine learning, a machine learning framework, we've been able to identify distinct phenotypes of AS severity. So this study was mostly focused on patients with severe AS. Most of the patients were asymptomatic. And still, we've been able to identify, using several echocardiographic features that have been actually selected by the machine, a high severity group versus a low severity group. You see this loop, and you clearly see two parts in the loop, the high severity and the low severity. And now we have, the next step was to validate these two groups that have been identified by the artificial intelligence algorithm and see if it would predict prognosis and different endpoint. And it was spectacular. It predicted very well the risk of AVR, the risk of death, the presence of myocardial fibrosis on MRI, and the extent of aortic valve calcification. So several validation, making this paper, I think, very robust. And actually, the final classifier that resulted from this paper and that allows to identify the risk phenotype to which the patient belongs is available online. So Pibarot made it available for everybody. You just have to enter the value of these 5 echo features that have been retained by the machine learning algorithm. So aortic valve area, stroke volume, peak jet velocity, mean gradient, and LV ejection fraction. And note that these 5 echo markers, are parameters that we measure in the context of a routine echo in any patient with aortic stenosis, of course. So this is just a patient that we saw last week, asymptomatic, exercise testing, good exercise capacity, no issue. And so valve area is 0.8, stroke volume is 32, stroke volume index is 32, peak jet velocity is 4.4, and there is a mean gradient of 47, LV ejection fraction 55. We just submit the results, and the patient fall into the high risk group, which means that this patient, although he is asymptomatic, could benefit of an earlier intervention. Of course, needs to be validated. And this brings me to my last slide, is to say, maybe we are close to a time where we'll see a randomized trial, such as the early TAVR and the expand trial and the progress trial, where actually the inclusion and screening will be based on the presence of a high-risk profile or high-risk phenogroup on artificial intelligence. So one trial that I would like very much to do is to include patients with symptomatic moderate AS or asymptomatic severe AS, because again, these are the two populations where we will need to individualize and optimize the timing of intervention. Then in these patients that will be screened, we will, by entering the 5 echo parameters, identify those who are at high disease severity by machine learning, using the classifier that we previously validated. And then you could randomize the patient to these patients who are at risk, not all comers, because my concern with the ongoing trials is that they're more all comers, and it's not all patients would benefit from earlier intervention. But if we focus on a group that is at high risk, we may have a better benefit of the earlier intervention. So that would be randomized to early TAVR versus clinical surveillance. Of course, we need to separate those two strata, the at-risk symptomatic moderate AS and the at-risk asymptomatic severe AS. And the primary endpoint could be a composite of death, stroke, or cardiac rehospitalization. So I think there is still some work to do, because the phenogrouping that we did based on machine learning is more adapted for patients with severe AS. We may need to do the same exercise for those with moderate AS. But anyway, that's an ongoing work that would be very interesting. But I think it's the future. We may see in the near future some AI-guided randomized trial. What would be AI-guided is essentially the inclusion, exclusion in the trial. And I think it's going to be very interesting. So on this, I thank you very much, and would like to thank my team, who are really those who are doing the hard work while I'm talking to you.
Wonderful, Philippe. So this has been a great presentation for us. And if you would just unshare your screen, then I will invite Dr. Abdul Hakim, who is one of our prolific structural interventional cardiologist, and also he's the director for the Interventional Cardiology Fellowship Program. So, this has been fascinating. And first of all, Philippe, your knowledge and your contribution are so enormous. It's been a great privilege to be involved in some of this work. And thank you for sharing all the data sets that you have been able for us to understand how do we apply some of these new technologies. I had a couple of questions, and as you were saying, the first question, like I really like the idea of staging, but how certain are you that the pathologies that are developing, let's say in the right ventricle, left atrium, are causally related to the aortic stenosis? So my question is, are they concomitantly appearing in a heart that is progressing through certain age-related comorbidities, which are all interlinked? Or is it a cause of the aortic stenosis? And particularly, it may be relevant because when someone is asymptomatic, of course, the burden is bad, but what does the pathophysiology suggest to you?
So, Patko, that's an excellent question, and maybe the one that is the most important to address. And I will provide a short, abrupt response and then a more detailed. The short, abrupt is to say there is no way to know if the cardiac damage staging is directly related to the aortic stenosis, or vice versa, if aortic stenosis is causal to the cardiac damage staging. But my next part in my response will be, I don't care. Why I don't care? Because if, let's say you have a patient with advanced cardiac damage staging and he has or she has severe AS. If the cardiac damage staging is directly related to the severe AS, well, it's just, putting more argument in favor of an earlier intervention, right? If, let's say, the cardiac damage staging is not totally or not related at all to aortic stenosis, it remains that the patient is still more vulnerable to this burden of aortic stenosis. Let's say the cardiac damage staging was related to a previous myocardial infarction or to a diabetic cardiomyopathy. Well, these patients will not be able to tolerate the severe AS for a long time, and will not be able to tolerate any progression of aortic stenosis, because he or she is handicapped, in terms of the cardiac function by another comorbidity, but it doesn't change the conclusion that probably you need to intervene earlier, because these patients are more vulnerable to the AS. So I think the causal relationship is not vital in this concept. I think we need to grade the severity of AS to see if it falls into the guideline indication, if it's severe AS. If it's not, for now, there is no indication. But otherwise, I think the cardiac damage staging may be useful, whatever is the really underlying cause, to trigger intervention sooner or later. Now, having said that, it is still important to try, although it's sometimes difficult. It's like the symptoms, If you would say in patients with AS, can I be sure that the symptoms are always causally related to the AS? In the elderly population with multiple comorbidities, very difficult. Same for cardiac damage staging. So, but still, it put this patient at high risk for worse outcomes. And I think it is an argument for having an earlier intervention. Now, the interesting aspect of looking potentially, if we are able to, the other possible cause of the cardiac damage staging or the symptoms is to be able to better treat these comorbidities also, because if you need a cabbage at the same time of the aortic valve replacement, you need to know. If you need to optimize the anti-diabetic treatment, you need to know. If you need to optimize the hypertensive treatment, this is important too, you see.
Very, very interesting. The reason I brought this up was, Philippe, was when we were doing this clustering, and at one place we saw that there were several patients looked to us, and again, and in one of the animal studies, in our previous studies, there was a concomitant reduction of the EF. I mean, I always thought that the aortic stenosis became severe, and then the stress increased, the wall stress, and the EF then went down. But it so appeared that the EF was falling simultaneous to the development of moderate to severe aortic stenosis. So maybe the comorbidities. I think we're still understanding all the players in this pathophysiology. So it's very interesting. But having said
absolutely,
that,
and you see, there has been some recent study, some published, some to be published soon, looking at cardiac damage staging in moderate AS. And it's interesting to see that it's not good, and that many patients, they are stage 1, 2, 3, 4. And you may say, oh yeah, because of comorbidities. But I think, you know, the parameters of LV systolic function that we are using the most is LVEF. And this LVEF, especially in patients with AS, it declined very late in the course of the disease, you know. And it's often when the LVEF decreases, it's not too late, but you're pretty much advanced in the disease. And the cardiac damage occurs well before the LVEF starts to decline, and at probably earlier stage than severe AS for sure. Still at moderate AS, we start to see, especially in the vulnerable population, you know.
Yes, Dr. Hakim. So, your comments.
That was an excellent talk. Thanks to Dr. Pibarot for giving us a perfect overview of the subject. I have just two questions, something that I often find very intriguing, especially when it comes to the diagnosis of severe AS, particularly in the D2, D3 variants. And one thing, in my opinion, which is often overlooked is the presence of concomitant mitral regurg. And as you know, about up to a third of these patients will have some degree of MR, maybe 15 to 20% would have moderate MR. And that often could lead to either overdiagnosis or underdiagnosis of severe aortic stenosis. And I have not seen that really in any of the algorithms as it pertains to the diagnostic criteria that have been laid out by either ASC or by the American College. Do you have a comment about that?
Yes, I think it's a so important point. The problem is that in the guidelines, you don't have much, you know, on multi-valvular disease. Generally, the disease are described like in silo. You have aortic stenosis, you have MR, but look at the section in the guidelines that is on multiple mixed valvular disease. It's half a page. Why? Yep. Because there is very little data published. Why? Because most of the big trials, talking about the partner, the core valve trial, etc., in the exclusion criteria, as soon as you have severe MR or severe AR or you know, any significant concomitant other valve disease, they are excluded. So we don't have data on this patient, unfortunately. But you're right, in the real life, these patients, they are there, you know, and about 1/3, as you said, of the low flow, low gradient, they have MR, and substantial MR. And this is a kind of a vicious cycle, because the MR contributes to the low flow state. It steals away some of the forward flow, right? So it is part of the problem, and it is one of the cause of the low flow state, you know, both in those with low EF and those with the preserved EF. And in terms of diagnosis, they are more challenging, because when you do dobutamine stress echo in these patients with MR, sometimes the response is unpredictable. Sometimes the dobutamine stress echo will actually worsen the MR, but not necessarily improve the forward flow. So you are still without answer at the end of the dobutamine. So what we do, I will tell you, when we have these patients, more and more we go directly to calcium scoring.
All right.
Nothing goes with low EF or preserved EF, because at least this is flow and hemodynamics independent, and at least you have something that is kind of independent method to confirm the stenosis severity. And if we have a calcium score that is high, we go for it. And then, of course, there is the other layer of complexity. Once you said, well, okay, I'm going to intervene on the aortic valve, I also intervene on the mitral valve. Now as a kind of concomitant procedure, or surgical transcatheter, or as a stage approach. Often, most of the cases, I would say in our institution, when we have confirmation of the true severe AS in a low gradient patient with MR, we do the TAVI first, because most of these MR are functional secondary, and we cross the fingers and hope that with maybe the treatment of the AS, the MR will go down and decrease, and we'll have to address it. If it persists and the symptoms persist, then eventually we'll do a TER down the road.
Mm-hmm. Yeah, I think that's been our practice too.
Yeah.
And then the other thing, you showed a really good outcomes graph of the D2 variant patients or the D3, where TAVR patients had the best outcome, followed by SAVR, followed by alternate access TAVR. Now, do you know, and I'm sure you're the core lab for a lot of these trials, what proportion of these patients would recover their LV function? What is really the mechanism by which because once the strain has gone down, that is really a surrogate for fibrosis, right, at the cellular level, and we have known that to be a largely irreversible process. So yes, you do replace the valve, you improve flow. That is the obvious mechanism. But do the LV mechanics, the performance index of the left ventricle, does that improve?
Yeah, I think this utility versus futility of the treatment of AVR, TAVR or SAVR, has always been, I think, a concern in low gradient AS. And both the classical and the paradoxical. Maybe even more the paradoxical, because you have patients, with pronounced concentric remodeling. They have, and these patients with low gradient AS, the low EF or the preserved EF, they have more myocardial fibrosis. And we know that fibrosis is regressing not as well or not at all after AVR, or takes more time. So sometimes you're disappointed by the results. You've done a successful TAVR or SAVR, and the patient actually does not improve in terms of LV function, and more sadly in terms of symptoms and quality of life. So we look into that in partner 2, and the different flow gradient pattern, and how was the outcome. And actually, interestingly, the patient with paradoxical low flow, low gradient, they had an outcome that was as good as the high gradient AS following TAVR or SAVR. Okay. The only group that was somewhat not as good was the classical low flow, low gradient with the low EF. This one, but the problem is in partner 2, we don't have a control group with medical therapy. And we know from other studies that conservative management would have been worse anyway. So clearly, these patients are at high risk. They have lower survival, after AVR than those with high gradient AS, but still is much better than doing nothing with the valve. So, and in terms of recovery of LV function, we've done a study in the past. It was not a huge number of patients, but in the context of the TOPAZ study, where actually you have some recovery of LV function in the classical low flow with the low EF. We see some improvement in LVEF. And in the paradoxical low flow, we've seen some recovery, not of the LV ejection fraction because it's already normal, right? But more of the stroke volume of the flow. It takes some time, more time. You don't see that at 30 days. You need to wait 1 year, but it recovers. And more importantly, also the diastolic dysfunction improves. The only subset of patients where we've not seen much improvement of, unfortunately, are those with the grade 3 diastolic dysfunction. Those with the restrictive pattern will probably have more extensive fibrosis. This population, unfortunately, I think we are a bit too far and too late.
Yeah, and Philippe, so I believe you would also agree one of the most challenging phenotypes that we face, and we face this day in, day out, are elderly female hypertrophied ventricles, atrial fibrillation, dilated atria, some functional MR, and then you have a stroke volume which is changing with beat to beat, and you're wondering it's severe or moderate. I mean, and then you do the procedures perioperatively, they will have fluid overload, their transiently will worsen, managing. These are some of the most difficult. And sometimes if they come with MAC, it becomes even more problematic because then they have. But
yeah, sure.
those are the
Mac
cases
on the
like,
top of that. That's
but those are the
stuff.
cases like we get and we wonder, well, how do we deal with the situations? I'm sure. I mean, also we see a lot of people have difficulty in really quantifying these patients because none of the quantitative tools, because of the variability with AF and all that stuff, it's a big challenge.
It's a very big challenge. I think, as I said, that's the HPEF form of AS. Yes. And we know that HPEF with AS or without AS is always difficult to treat. And we don't have good solutions. But at least, if it's an HPEF related or associated with CVAS, that I think the approach is really to, in this type of patient, W-time stress echo is certainly not the way to go to confirm the stenosis severity. So clearly, this is where, calcium scoring, although it's not perfect, it's not a panacea. As I said, there are some false negative cases, and we need to be more comprehensive. And sometimes, in some cases, you don't even need a calcium score. I'm sure the case of paradoxical low flow gradient that I showed you, Parto, you look at the video clip of the parasternal short axis and parasternal long axis, and you would say, "Hey, Philippe, I don't need the CT. I know it is severe." But anyway, at least the calcium scoring by CT, it gives you a number. It gives you an argument to say it is really severe. And if the stenosis is severe, I would say whatever is the underlying phenotype or variant, as Abdul said, I like this terminology, the D2, D3 variant. I think, we have to do something with the valve. We have now enough data to say if you have a severe stenosis, unless the life expectancy is less than 1 year for whatever reason, then of course you should not intervene. Otherwise, you should do something with the valve. And on the other hand, this is a population that is at high risk at high surgical risk generally. This is not the type of patient that the surgeon, the anesthetist, and the intensive care guy like very much because, as you said, they are very difficult to manage perioperatively. And I think this population, once you know that the stenosis is severe by calcium scoring, probably transfemoral TAVR, the least invasive is the way to go. Be minimally invasive is the really the way to go because to make the patient go through.
Yeah. And now last point before, I know we are getting long, exercise in these patients. Some of these people are so frail and elderly, and it's challenging. So do you use supine bike or do you use the treadmill?
Yeah, we use supine bike, and we've published a study using exercise stress echo and even dopamine stress echo in some, but mostly exercise stress echo, what is probably more physiological and more adapted for this patient, and we use supine. The problem is that these patients are often, as you said, frail. They are often symptomatic, so they will not necessarily bike for long. But yeah, there are some paper in the literature, showing the utility, confirmed stenosis severity. But I think, again, given that we have CT calcium scoring, I'm not sure there is a big role for exercise testing in this population.
And I have a suggestion. Why not do some digital biomarkers like, activity monitors? Because, many of them falsely reduce their lifestyle activities and all. And I think that might be a good surrogate for our, the amount of NYHA class reclassification that could happen. because we have seen that. I mean, and sometimes it's difficult to get they say that, oh, we are fine, but actually they're not doing anything.
Right. No, I think actigraphy and all kind of tools that we could use, to both pre and post intervention, and during also the longitudinal follow-up that we do during intervention, if we could not only measure, because we put a lot of attention and time on doing the echo and the imaging and eventually blood biomarker BNP and NYHA class, but NYHA class is not sensitive enough. But if we had like tools that measure more objectively the activity of the patient, and we follow longitudinally, when we start to see a decline, although the patient will say, oh no, I'm fine, doctor, he will say, hey, maybe it's time to go. So no, I totally agree. And then looking, it would be great to have a study where we longitudinally follow this prior to intervention, and then look after intervention how it recovers or not sometime, because
yeah, absolutely. So, I mean, I'm just mindful of the time. So I want to, so it's just amazing. So, and, Mark is on a flight, and believe it or not, he joined in from the flight and he's listening to us. So hi, Mark, and he was supposed to be in the panel, but we're going to do these collaborations. And I think as we are, Dr. Hamid and Mark and others, we have a very robust group of people as we develop these collaborations. And we look forward to really partnering with you on some of these clinical trials and in the fundamental quests and also machine learning and other technologies. So we really look forward to doing this with you, Philippe. So
no, for sure. And I can tell you that your institution and team has a very strong reputation in the field of valvular disease management. Yeah, absolutely.
Great. Mark will be very pleased to hear that. Thank you. And we are all very excited. Yes.
And I would love to do more collaboration.
Yes,
for sure. We stay in touch.
Thank you for having me. Thank you, Abdul, and thank you,
Philippe.
So good night. Bye-bye.